Having a child is every couple's dream, but we do have problems sometimes. I am Dr. Subramanyam, consultant urologist and transplant surgeon from Apollo Hospitals Jubilee Hills. Today I will be talking to you about male infertility. It is said that it takes two to tango. You require a normal woman and a normal male to have a child. Now, when we talk of patients who do not have children or who have difficulty getting a child, we have to look at both the angles. The woman who is examined by the gynaecologist and the man who comes to us with problems of infertility. The most important test which we do in patients or men who come to us with infertility is a semen analysis, apart from a clinical examination. Now, when we do a clinical examination, we would look at the testicular size because that's where the sperms are produced. We do get sometimes men with very small size testes, which what we call atrophic testes, and because of the size is small, they don't produce enough sperms, and that will produce problems. Sometimes we do get men who have got what we call undescended testes. Normally the testis is outside the body for a reason. The temperature inside the abdomen is more 1 degree centigrade more than the temperature which is there in the scrotum. Normally when we are in our mother's womb, the testicles are inside the abdomen, and as the child develops, the testicles descend and they come out of the abdomen into the scrotal sac, and this is where they lie all their life because the temperature here is about 1 degree centigrade less than the abdominal temperature. But we do see some men where the testis doesn't descend, and this, if it is neglected during the childhood and was not operated upon, the testicles stay in the abdomen and these testicles stop producing sperms. So when we do a physical examination, we look at whether both testicles are descended, and if they are descended, if they are normal in size and consistency, and also to see for any other abnormalities around the testicles and in the scrotum, like dilated or distended veins. But the basis of investigation for any patients with infertility is a semen analysis. Now, a semen analysis is a sample of semen which is sent to the lab to look for various parameters which we see in the sperm, in the semen. Now, the important thing about a semen analysis is again proper collection. We see a lot of patients who collect a small amount of semen and give it in the lab, but they do not collect the whole sample. So what we tell our patients is that they should have 3 days of abstinence, that is 3 days they should not ejaculate. On day 4 or day 5 they masturbate and collect the sperm which comes out. Now they have to collect every drop of sperm because every drop of semen has to be collected and without any spillage. Now we tell our patients that if there was to be a spillage, don't give that sample, wait for another 3 days and collect another sample. The reason for that is a lot of management hinges on the semen analysis, and when you do a sample of the semen sample has to reach the lab within about 15 to 20 minutes. So there is no point in collecting a sample, keeping it home and bringing it back in an hour's time, and you would get all sorts of abnormal results in that. Now when a sample reaches the lab will look at a variety of parameters. The first thing they look at is the volume, how much semen was there. Normally about 3 to 5 ml of semen is produced at every ejaculation. So they will look at the volume. The second thing they will look at is the number of sperms. This is one of the most important parameter which we go by. The normal sperm count is about 60 to 120 million per ml. So if you take an ml of semen, you get 60 to 120 million sperms. And the minimum required to produce a normal pregnancy is anywhere between 12 to 20 million. Previously the WHO had a standard of 20 million, now they brought it down to about 12 million. So at least 12 million sperms per ml must be there for somebody to expect a normal pregnancy in a natural way. Now the third parameter we look at, apart from the volume and the number of sperms, is the quality. When we talk of quality of the sperms, we would look at the motility, how many of them are moving. The sperm has got a head and a tail, and the tail wags and therefore the sperm moves. And motility is a very important parameter because if you see how pregnancy occurs, the sperms are deposited in the vagina and the sperm has to move from there through the uterine cavity so that it can meet the ovum there or the egg there to produce a pregnancy. So motility is a very important factor, and when we look at motility, we look at whether it is actively motile, sluggishly motile or non-motile, and we would expect at least 35 to 40% of progressive motility in a normal semen analysis sample. Now we will also look at the morphology. How many of them are normal looking, how many of them are abnormal looking. Some of them don't have a tail, some of them the heads are distorted. So we would look at the morphology, and we'll also look at whether how many of them are live and how many of them are dead. So there are multiple parameters which we look at in a semen sample. Now, simple thing to understand is there are a lot of small things which can affect a sperm count. Somebody getting a common cold or a small viral fever can also affect your sperm count. So it is always a dictum that you go with not one sperm and semen analysis report, but probably repeat it 2 or 3 times over a period of 1 to 2 months. So never start treating somebody with one semen analysis report. It's always worthwhile repeating it again in about a week or 10 days time. Now, if the semen analysis shows an abnormal value, sometimes we do see patients where the semen analysis is 0, what we call azoospermia. So in patients with azoospermia, there are multiple other investigations which we do to find out why the sperms are not there in the semen. Now, if you look at azoospermia where there are no sperms in the semen, there are only 2 reasons. One is either sperms are not being produced from the testicle and so nothing is coming out, or sperms are being produced from the testicle but there is a block in the tubes which bring the sperms from the testicle into the urine pipe, which we call obstructive azoospermia. To differentiate whether the patient has got an obstructive azoospermia or a primary testicular failure, we would do a blood test called an FSH. FSH is a hormone which is produced by the brain, and that would regulate how the sperms are being produced. So if the sperm production is not there, the FSH value will be very high. So a very high FSH in somebody with azoospermia, that is 0 sperm count, usually indicates a primary testicular failure. Now if the FSH is normal, then we would probably go for what we call a testicular biopsy, where we take a small piece from the testicle, doing a small operation and send it to the lab. This testicular biopsy will tell us if the sperms are being produced from the testicle. So if somebody has got azoospermia, no sperms in the semen, and the testicular biopsy is normal, the logical conclusion would be that he has got an obstruction to the passage of the sperms from the testicle to the urine pipe. And in these patients, a microsurgical recanalization would probably be the answer to their problem. Now, we see sometimes patients with low sperm counts which are low in both number as well as quality. Now, if somebody has got a low sperm count, the first investigation which majority of us do is what is called a Doppler scan for the testicle. Now, this Doppler scan will look at a condition called varicocele. Now, varicocele is a condition where there is more blood flowing around the testicle, and as I said, the testicles are kept at a cooler temperature because they are outside the body. Now, if the more blood starts flowing around the testicle, obviously the testicle gets warmed up, and this would affect not only the number as well as the quality of the sperms which are produced from the testicle. So if somebody has got a varicocele, and these varicoceles are very common on the left side, and sometimes you do see them on both sides. If somebody has got a varicocele, a microsurgical surgical procedure to correct the varicocele would probably improve their sperm parameters, both by way of count as well as motility. So if the sperm count is low, we do a Doppler scan to find out if there is a varicocele, and if there is a varicocele, we would advise the patient to get a microsurgical procedure done to correct the varicocele. Now, sometimes we do see patients where the sperm count is low or the motility is low, but there is no obvious reason for that, and this is what we call idiopathic infertility. That is where no obvious reason is there, and therefore the count, we do not know why the count was low. There could be a lot of reasons for that which are hypothetical, but we won't be able to correct it. And in these patients, if the count is reasonably okay, we would try some hormone tablets to try to improve the count for about 3 to 6 months, and then repeat the count and see if the count can be improved. But if the count is very low, we would probably ask them to go and get some sort of artificial reproduction techniques assistance for getting a pregnancy. and these sperms can be concentrated by collecting 2 to 3 samples and then doing what is called an intrauterine insemination in the woman so that they can get pregnant, or they can go to some sort of IVF so that they can get a pregnancy. So male infertility is a big factor in working up of an infertile couple. But doing a semen analysis is a very simple test, and we also see that there are a lot of couples who go to the gynecologist first for getting an investigation. But of all the tests which we do for infertility workup in a couple, semen analysis is the simplest. So I think if you see an infertile couple, the first investigation we should do probably is semen analysis before the woman is investigated or before any further investigations are done in men.